It's a honor and privilege to sort of start off day two of the CPP International Conference. This particular module is anchored around looking at health, specifically looking at primary health. Primary health, as all of you would know, is the first sort of point of contact for most of us, ranging from things like fever, diarrhea, all the way to something a little bit more serious, which includes like having some basic injuries, etc., etc. Much of non-communicable diseases is largely in the health primary health space. So this is like a part of the healthcare system which doesn't sort of see significant uptake. And what we are going to do in this session is start off a little bit by talking about some of the research findings that we've been working on from the states of Jharkhand and Karnataka. We've looked at two different states at two different levels of development, both in terms of economics as well as in terms of giving significant variety in terms of how the health system has sort of evolved in terms of dealing with its state-specific challenges. To talk about the two states, we have three officers from the government of Jharkhand and government of Karnataka. So I'll quickly introduce the speakers. We're running a few minutes late, but hopefully we'll be able to catch up as we go. So let me begin by introducing from the left, we have D. Randeep. He's an Indian Administrative Service Officer, currently serving as Secretary to the government's Scheduled Tribes Welfare Department in Karnataka. He's held various key positions in the state, including with the Bruhat Bengaluru Mahanagar Palike and the health department, from which he will be sort of sharing his experiences. He's widely known for his work in areas ranging from digital health, COVID management, and of course, solid waste management. Sitting next to him on his right is Dr. Kamlesh Kumar, who is MD Medicine. He is currently with the Jharkhand State Health Services from 1997, has vast experience of public health as a medical officer in charge at the CHC in many blocks of Jharkhand. He was very active during COVID, and he's presently the state tuberculosis officer and comes quite frequently to NTI Bangalore. He's heading the NHM Jharkhand team for many years. He's the state nodal officer for comprehensive health cell, RSK cell, NUHM cell, SPMU cell, and will sort of be reflecting on how the primary healthcare sort of approaches on the ground, on the operation level, are sort of affecting us. And sitting to his right, we have A.K. Minaj, who has done a master's in social work from Savitribai Phule University and currently working as state program coordinator and manager in National Health Mission Jharkhand. She's been engaged with community capacity building focused on tribal people for over the last 26 years. She's leading the community processes unit from National Health Mission Jharkhand. She's leading the participatory learning and action initiative with 40,000 SAIAs, or what we broadly know as ASHAs, in Jharkhand. So that's the entire cohort of ASHAs from Jharkhand. She's the recipient of the COVID Warrior National Award, and she's a fellow of the Visionary Leadership Management Program in Africa and Asia. So we also have moderating the panel, Dr. Prashant, who is currently leading the Institute for Public Health Bangalore, and he's a medical doctor by training, a health systems researcher, presenting on international forum on like thinking about healthcare and how healthcare sort of is impacted, can be improved, etc., etc. The research team that we are sort of looking at is essentially a team anchored with Prashant's team and Ekjut, which is also here from Jharkhand. So Dr. Nirmala Nair and Rajkumar Gop, who represent Ekjut, the NGO. And I'm Bangalore, so Bangalore is the anchoring entity for this research project. And so we thought this would be a nice forum to essentially present some of the research that's emanating out of this body of work, and also see some responses from active government officers who've been sort of working in this space. Okay, so guys, where is the presentation? This is the presentation of the Thanks. Let me just go full screen. So So therefore, there is like this research team which is at the background, which is called the PHC for UHC. So that's the short name. It's looking at primary healthcare and how it's impacting universal health coverage. Remember, it's a national sort of commitment to talk about UHC, and we're looking at how PHC impacts that. And we're sort of going to go in this format. So I'll do a little bit of an introduction. Sharmada, who's also part of the team, and I will talk a little bit about the research, and then we'll hand over to Prashant to essentially work with Mr. Randeep, Dr. Kamlesh, and Ms. AK to essentially drive out some of the implications. So without further ado, the longer I speak, the less time our distinguished panelists have. So let me simply jump in. This is the study that we've been looking at. If you think about India and you look at the complexity of India, virtually every state is a health system in its own right. Okay, so the complexities of the state are essentially both in terms of state capacity, in terms of how capacity sort of is interacting with the complexities, both in terms of epidemiological and economic structures in which healthcare is sort of defined. And so as a part of the study, we looked at Karnataka down in the south, which has higher levels of economic development, also has higher levels of health systems utilization. And there's, of course, Jharkhand, which is a relatively newer state carved out in 2000 and is looking at a whole range of parameters which sort of contrasts quite significantly with Karnataka. And therefore, what we do in this kind of study is look at how primary healthcare is affecting universal health coverage in both these two types of different kinds of state ecosystems. Within each of these two states, what we have done is we've done a benchmarking exercise using the WHO World Bank framework for looking at how universal health coverage is measured. So these are sort of approaches of using population level survey data to try and understand where are we with terms of delivering healthcare. And so what we've done is we have classified each of the districts within Karnataka and Jharkhand and actually the entire country in terms of where they stand in terms of achievement of UHC. And so we've essentially looked at 6 study districts within these 2 different states. So in Jharkhand, we've been looking at Sahibganj, Paschimi Singhbhum, and Saraikela Kharswan. And in Karnataka, we've been looking at Bagalkot, Chamarajanagar, and Bangalore Urban. So these are the 3 plus 3 districts. We are studying them as a part of the first part of the study, which is a quantitative study on PHC inputs and UHC domains. So these are what we have measured with, and this is a measurement framework that we are creating as a part of this study. And we're essentially looking at trying to understand what constitutes PHC inputs, what constitutes WHO's UHC framework, and how can we measure them in sort of a standard measurement way so that we can continue going back and forth on, seems to be stuck. Okay. So the way to think about this is consider yourself a district collector. If you're a district collector, then you are in charge of a district and you are trying to essentially anchor 54 government departments, run between 200 to 300 schemes, and you have state capacity at your beck and call to try and work on these schemes. So the question we're trying to answer is, in that sort of framework, can we find a measurement framework that will tell us how to inform the district collector where to park his energy in terms of time, energy in terms of resources, to try and move the district higher up on UHC, looking at schemes which are directed towards the PHC. So that's kind of the framing of sort of why we're trying to do this from a practice perspective, right? We have PHC and UHC measured in these domains. So if you're looking at PHC, remember this is PHC inputs. So the idea is you are doing things on the PHC front in terms of schemes and interventions which act as inputs. And we are trying to essentially assess how universal health coverage in terms of the output side is going to be impacted because of that. And for those who are doing evaluation style sort of conversations, we're not doing the kind of stuff that we did in the workshop because we are very rudimentary. We don't even know what we are measuring. So it's very much of a correlational study. So what we do is we focus on measurement, and for PHC inputs, where we are focused on is looking at performance indicators. We've looked at the quality of primary healthcare indicators. We've looked at the capacity of the district in terms of giving out primary healthcare. We've looked at health financing and access to primary health sort of variables. And we've essentially used like a standard format in which for each of these domains, for each of the indicators, we have a geometric mean for each of the inputs. And across the 5 domains, we have like another geometric mean to give a consolidated number for each district in the states of Karnataka and Jharkhand. For the UHC, we're looking at different indicators. We're looking at reproductive health, maternal health, neonatal and child health, non-communicable diseases, service capacity and access, and financial risk protection. Again, we do the same kind of activity for each of these 6 domains, 5 domains. We are doing a geometric mean of the indicators we have chosen to come up with a domain-specific indicator. And for that, we are collapsing further to create a single number for every district. So essentially, we have a single number which is measuring PHC inputs and a single number for. So what does that look like? This is what the Jharkhand map looks like for PHC and UHC. The one on the right, the one in blue is your UHC. So the deeper blue you are, the higher the UHC. The deeper red you are, the higher the PHC. Okay, so this allows us to range a bunch of different types of questions. We do the same for Karnataka. And then we can essentially identify for each of these kinds of high versus low kind of districts in terms of PHC and UHC. So you could be high-low on UHC, you could be high-low on PHC. So we can now ask, are you a high district, high PHC, high UHC, low PHC, low UHC, and therefore how are you different from each other? So we can try to back that into sort of some of the domains that we are looking at. So here we have a classification of both Jharkhand and Karnataka into high, high, low, low. So the blues are high highs and the deep red greens are the low lows. So this is indexed to each district, each state's performance. Remember, the states are vastly differentiated on a common scale. So we have sort of anchored this onto each state's different scales. Broadly, if we were to put this on a map and look at PHC inputs versus UHC outputs, we have like a nice linear regression kind of relationship between the Jharkhand and the Karnataka sort of indicators. So this is exactly what we wanted. We wanted a variation on the PHC and UHC scale so that we can talk about different kinds of performance indicators. We have a positive relationship. Each of the domains of the PHC indicators. Remember, we had 5 domains for PHC measurement. Each of those domains are positively correlated with the UHC output index. So there's a clean mapping that we have associated with this. We can go for a little while. We have regression models that are sort of looking at the relationship between PHC and UHC. Broadly, there's a strong sort of relationship that exists, and it sort of exists even when we try and control for a significant number of things at the district level, both for Jharkhand as well as for Karnataka. I don't want to spend too much time on this side, and I'm going to move on to the case studies, wherein we are trying to understand what are some of the pathways that we are trying to follow from the PHC side interventions to try and link it to UHC side interventions. So I think that's where Sharmada, who is being sort of anchoring most of this work, is going to take over. And yeah. You can. Yeah.
Hold it.
Yeah.
Hi. Hi, my name is Sharmada Sivaram. Good morning, everyone. On behalf of my team at Ekjut in Jharkhand and IPH in Bangalore, I'll be presenting on the case studies. So, in diverse settings, how do you understand how PHC inputs can lead to UHC outcomes? So, we conducted 3 case studies in the 2 states. One that was common based on a national program, and 2 that was specific to the states. This is Ayutthaya and Arogya Mandirs that are formerly known as health and wellness centers in both states, which are, of course, India's sort of flagship CPHC program. And with upgraded infrastructure, new with free drugs and diagnostics and community-based screening and outreach, which sort of represents the PHC pillar of integrated service delivery very well. In Karnataka, we looked at the Tribal Health Navigator program, which provides health system navigation in secondary and tertiary hospitals for patients from Adivasi communities through a navigator who is from their community and trained to do so. It also speaks to multi-sectoral engagement, given the convergence between the health department, the tribal welfare department, the sanghas of the Adivasi communities themselves, and CSOs. In Jharkhand, we looked at participatory learning in action, which really exemplifies how community engagement can be done institutionalized way. It's an inclusive participatory learning platform, which is facilitated by ASHAs and ASHA facilitators. And the groups engage on a range of topics related to PHC and entitlements. I won't really go into how diverse the two states are because I know Professor Mukherjee really covered that well. We did primary data collection in the two states through in-depth interviews and focus group discussions through a range of stakeholders in the health system, from administrators all the way to the community. I won't really be presenting thematic findings today, but rather like a distilling of what we think are some of the pathways that can take these inputs toward UHC outcomes and some of the contextual factors that could make a difference. So inputs, as I mentioned, and of course, those are the standard UHC outcomes. We feel like the expansion to comprehensive primary healthcare services in both states is sort of well reflected in the state. Participants reported, accessing care for NCDs that they hadn't previously done so, which are at facilities that are closer to home. This also meant that they weren't necessarily traveling great distances to access care at secondary or tertiary facilities, and they had something close to home. Second is like building responsiveness in the public services through a well-equipped PHC team. So in addition to the auxiliary nurse midwife, the ASHA worker, we now have a new cadre called the community health officer, who are trained in public health and also to provide a broader range of services. So we felt like this was a factor that was helping build trust in the public health system. Further, we also noticed that local governance, so for instance, the Panchayati Raj institutions and their sort of active support and engagement with the facility and the staff members could really make a difference, and especially to sort of address some of the infrastructure issues or community mobilization, for instance. Community engagement is, of course, a part of the Ayushman Arogya Mandir sort of strategy, but at this point, outreach and screening can also be further strengthened by other ways, we feel. Some contextual factors that could sort of facilitate or hinder this is the motivation and the sense of purpose amongst providers to, feeling responsible for the catchment area and their population. Further health system factors such as infrastructure, human resource availability, shortages, and trust in the public health system itself. These are sort of broad linkages of how we would link it to these sort of UHC outcomes. Like I mentioned, wider range of services. We also have now free medicines and diagnostics available closer. In Jharkhand, we noticed that CHOs also were really driving outreach by visiting communities, like especially the remote and tribal groups. In Karnataka, participants reported that more elderly patients were coming into the facilities now, and as well as male patients. Financial risk protection, a big factor seemed to be free medicines available, especially for hypertension and diabetes. But of course, in some geographies, depending on the situation, out-of-pocket expenses on transport remain significant. Moving on to tribal health navigators. So a critical thing is culturally sensitive navigation in these secondary and tertiary hospitals, especially for communities who haven't historically had representation in the health system and are sort of don't have as much of a familiarity either. So this sort of building trust, especially since the THN is somebody from their community. So there's more of a push to be able to access care. A big function of PHC is also ensuring continuum of care. So having a THN placed at a facility that's secondary and tertiary sort of also facilitates effective referral pathways. And finally, a multi-sectoral collaboration between the tribal welfare department, the health department, the Adivasi Sanghas, sort of creates a very supportive ecosystem for the program to function. Other contextual factors like are actually the characteristics of the THN themselves, which is that they're local, they're from the community, they're responsive, they're available all of the time. There's also like a lot of local buy-in and active engagement of the sanghas themselves at the design and implementation. There's multi-sectoral ownership, so it's not just seen as a health issue perhaps, and program designed towards sustainability. Like I mentioned, placement of PHNs in these hospitals has definitely, it's leading to an increased utilization of services by patients of tribal communities. There is a bit of a like opportunity to integrate with primary healthcare systems in the public sector better right now. And population coverage is pretty obvious. There's a lot more trust built. And of course, there's also reduced reliance on informal or private providers from before, because they're connected to the public health system where a lot of services are available for free. But out-of-pocket expenses on transportation, caregiver costs, etc., still remain high. Moving on to PLA, the participatory approaches and tools to engage communities are help make these complex health issues very understandable, and these are on relevant topics for the communities. And that's sort like the approaches themselves are very listening. Further, we also notice that they're really strengthening the women's capability to make choices of like they want to now deliver at facilities as opposed to home. They're aware of a lot of say linkages to the public health system, for instance, the entitlements and so on. Community ownership is sort of built into the design. For instance, the community has a big say on when and where these meetings happen, which actually really bolsters them to attend them and engage. And there's also multi-sectoral collaboration amongst both health service providers, Panchayati Raj institutions, and other frontline workers such as Jal Sahiyas, etc., locally to disseminate information and provide services. Some contextual factors, again, it comes down to the person's like local and trusted. Of course, there's also wider participation across population groups and support for facilitators themselves in terms of workload and trainings. There's been increased sort of awareness and therefore an encouragement to use essential health services in the public sector, preventive practices, and timely utilization of services. The design is very inclusive, and like I said, community ownership is sort of built into it, which really enables participation across the board. And there is a trend of decreasing reliance on informal providers according to the people we interviewed and met. And therefore, they reported using more free and subsidized care under government programs. These are some of the sort of broad reflections we have, which is about strengthening PHC really requires institutionalized and meaningful community engagement, which is critical to building trust and responsive care. Further, like global UHC agendas often prioritize very standardized sort of programs, but PHC really requires local flexibility and local leadership and ownership. Where in communities where health is often not the top priority, we need to think about multi-sectoral approaches to sort of strengthen relevance and participation. And of course, call for more participatory methods to generate actionable research. I'm going to stop here and move on to Prashant.
You okay?
Yeah.
Thank you, Sharmada, and thank you, Arnab. I think this really sets the stage for really a dialogue because we have as panelists people who are deeply embedded in the system. So what I'm going to do is I'm going to be posing questions to our panelists and try to create learnings for all of us together through their experience, because on the panel you have people who are not typically researching or doing case studies, but people who are on a daily basis dealing with a system that is extremely difficult to bend and move in ways of efficiency and effectiveness, what researchers like to study, right? You have such a large health system that they are managing, and they are trying to see how to improve outcomes for people, and it's not easy because of the very nature of these large systems. One thing that we missed on the slides is the rich photographs. I've had the privilege of looking at the tribal health navigators, because from the institute we worked quite closely with the tribal welfare department in supporting the design and implementation of it. And I've had the privilege of visiting Ekjut and areas in Jharkhand, where in remote rural areas, the state health system is championing the presence of infrastructure, Arogya Mandirs, medicines. Correct. Thank you, Arnab. Thank you. Indeed, I think the one in the middle is from Chamarajnagar, the Tribal Health Navigators. And the one on the top is an Ayushman Arogya Mandir in Jharkhand, I think. And the one below is actually a PLA activity, which is happening. And it happens across remote communities in Jharkhand, periodically bringing women and several men, adults, children together into a participatory learning space, which gets created and owned by communities in these places. So it's really very, very special opportunity for learning together. First, to our guests from Jharkhand, I would maybe, sir, Dr. Kamlesh, maybe I can ask you a little bit about primary healthcare, because I was just telling, I was just discussing earlier, primary healthcare, sir, often gets becomes invisible, no? Because UHC and so many schemes, Ayushman Bharat now provides reimbursement, and that is very visible. You know, it immediately saves lives. So be it at the directorate or at the elected representatives level, that sometimes takes more of the investment. So in Jharkhand, Dr. Kamlesh, can you tell us a little bit, how have you gone about trying to prioritize investment in Ayushman Arogya Mandirs, primary health centers, ANMs, ASHAs, the whole thing?
Thank you, Prasanji, and respected Principal Secretary, sir, and CEO, AIMS, and Execute team, and delegates of this conference, and PhD student. सबसे पहले तो हम लोग को समझना होगा, पहले तो इंडिया को समझना होगा। इंडिया में हमारी क्या समस्या है, पहले बर्डन, पहले सबसे पहले हम लोग जब किसी काम को करने निकलते हैं तो पहले हम लोग बर्डन को असेस करते हैं, फिर हम लोग चैलेंजेस देखते हैं, फिर हम अपना रिसोर्स देखते हैं, फिर हम लोग वे फॉरवर्ड की बात करते हैं। तो हम लोग जब इंडिया को देखते हैं तो इंडिया का जो अभी पॉपुलेशन है 144 करोड़ अभी हम लोग कह सकते हैं, और डाइवर्सिटी है, आप सभी इसको समझते हैं, और डेवलपिंग कंट्री, तो डेवलपिंग कंट्री में क्या डिजीजेज होती है एक समझना होगा। तो सबसे पहले तो इन्फेक्टिव से हम लोग शुरू करते हैं कि वेक्टर बॉर्न डिजीज है तो मलेरिया होगा, डेंगू होगा, चिकनगुनिया होगा, कालाजार होगा, जापानीज इंसेफेलाइटिस होगा, फाइलेरिया होगा, है ना, उसके साथ में आपको डायरिया, डिसेंट्री जो भी है। तो इन सब बीमारियों से हम लोग जूझ रहे थे 100 बरस पहले। लेकिन जब 1928 में पेनिसिलिन का इजाद हुआ तो फिर हैजा और प्लेग से हमारा मोर्टेलिटी कम गया। तो पॉपुलेशन पर भी दूसरा बात यह है कि अभी किस स्टेज में है इंडिया पॉपुलेशन के ग्रोथ में। तो एक समय था 100 साल पहले कि बहुत लोग मर रहे थे और बहुत लोग पैदा हो रहे थे। तो आप लोग इसको तो पहले से बहुत लोग स्टडी किए होंगे, तो इसको हम लोग हाई स्टेशनरी फेज बोलते हैं। बहुत सारे लोग मर रहे हैं और बहुत सारे लोग जन्म भी ले रहे हैं, तो ये हाई स्टेशनरी फेज जिसको बोलते हैं। जब पेनिसिलिन का इजाद हुआ तो जब हैजा प्लेग से लोग का मरना कम हुआ तो मॉर्टेलिटी घट गई, लेकिन पॉपुलेशन का ग्रोथ वैसा ही था। तो इट वाज एन एक्सपेंसाइल, अर्ली एक्सपेंसाइल फेज में पॉपुलेशन था, ठीक है। अब उसके बाद में फैमिली प्लानिंग कार्यक्रम हुआ। तो जब हम लोग फैमिली प्लानिंग कार्यक्रम को बढ़िया से जब हम लोग रन कर रहे हैं आज के तारीख में, तो फर्टिलिटी रेट घट गई। तो उससे क्या होगा कि पॉपुलेशन ग्रोथ भी घट गया और मॉर्टेलिटी भी घट गई। लेकिन पॉपुलेशन इतना नहीं ग्रोथ घटा कि अभी हम लोग स्टेशनरी फेज में गए। तो इट इज अर्ली लेट एक्सपेंसाइल फेज में हम लोग अभी हैं। उसके बाद में एक समय आएगा कि आपका पॉपुलेशन ग्रोथ इतना घट जाएगा और मोर्टेलिटी भी घट जाएगी, तो एक लो स्टेशनरी फेज में आप चले जाएंगे। यूरोपियन कंट्री में अभी क्या है कि वहाँ पॉपुलेशन ग्रोथ के लिए लोग काम कर रहे हैं। तो अभी हम लोग पॉपुलेशन कंट्रोल की बात नहीं करेंगे, अभी हम लोग बात करेंगे स्टेबलाइजेशन की बात करेंगे। तो ये हमारा इंडिया है। दूसरा है कि जब हमने बात किया कि इन्फेक्टिव डिजीज को हम लोग डील कर रही थी पूरी भारत सरकार, तो बीच में अब क्या इमर्ज हो रहा है, शिफ्ट हो रहा है। क्या शिफ्ट हो रहा है? एनसीडी। एनसीडी शिफ्ट हो रहा है, नॉन कम्युनिकेबल डिजीज है। इसमें क्या है? हाइपरटेंशन है, डायबिटीज है, ऑटो इम्यून डिजॉर्डर्स है, आपका रेस्पिरेटरी डिजॉर्डर्स हो गया, और इसी तरीके से कैंसर हो गया। तो ये सब एनसीडी में आ गया। और मजे की बात कि वेस्टर्न कंट्री कैंसर और इसके हार्ट डिजीज, कार्डियक हार्ट डिजीज और इन सब चीज़ों को बढ़िया से टैकल करती है वेस्टर्न कंट्री। लेकिन खुशी की बात है कि इंडिया भी एनसीडी को भी बढ़िया से टैकल कर रही है और नॉन एनसीडी जो कम्युनिकेबल डिजीज है उसको भी टैकल करी। ये दोनों को बैलेंस करके इंडिया की खूबसूरती है कि दोनों को मैनेज कर रही है विथ आवर दिस एग्जिस्टिंग वर्कफोर्स। तो ये हमारा दोनों बर्डन है इस देश पे। बीच में थोड़ी देर के लिए कोविड आके इन्फेक्टिव वाले कंपोनेंट को थोड़ा सा हाई कर दिया। अब उससे फायदा क्या हुआ कि गवर्नमेंट ने बहुत सारा फंड जो है हमको दिया। पहले तो ECRP 1 में फंड दिया, तो रनिंग कोविड को डील करने के लिए। बाद में सर बताएंगे, जानते हैं कि ECRP 2 हम लोगों ने कर दिया ताकि आप इंफ्रा को बिल्ड कर दिए। PM अभीम हो गया, ECRP 2 हो गया, NHM का फंड होगा, 15 फाइनेंस हो गया। इन सब फंडों से बहुत सारा बिल्डिंग बन रहा है और एपेक्स ओपेक्स जो भी है सब चीज के लिए उसमें कैपेक्स ओपेक्स सब चीज के लिए पैसा सरकार ने दिया। अभी हम लोग उसको रन कर रहे हैं, फैसिलिटियां बन रही है। तो ये तो हो गया। अब जो है कि हमारा झारखंड को अगर हम लोग समझते हैं या कोई भी ऐसा डेवलप स्टेट के बारे में समझते हैं, तो अभी हम लोग अगर एक धनबाद एक डिस्ट्रिक्ट है झारखंड में, अगर आप वहाँ चले जाएंगे तो एक दिन में एक शर्ट पैंट आप पहनेंगे, दूसरा दिन दूसरा पहनना पड़ेगा। लेकिन रांची में एक शर्ट पैंट आप 3-4 दिन भी पहन सकते हैं। तो ये डिफरेंस है, डाइवर्सिटी है। अब रहा बात कि अब वहाँ के जो लोग हैं उनका लंग का क्या स्थिति रहेगा। जमशेदपुर में यूरेनियम निकलता है तो वहाँ का कुछ और स्थिति होगा। कुछ गुमला हो गया, लोहरदगा हो गया, चाईबासा हो गया, खूंटी हो गया, यहाँ पॉपुलेशन ट्राइबल पॉपुलेशन पूरे देश में 8.9% ट्राइबल पॉपुलेशन है। सर एग्री होंगे तो। लेकिन झारखंड में 33% ट्राइबल पॉपुलेशन है और उसमें भी प्रिमिटिव ट्राइब जो है 5-6 तरह के प्रिमिटिव ट्राइब्स हैं। मैडम जान रही है निर्मला जी। उसमें अगर नाम हम लोग कहें तो बिरहोर है, कोरबा है, असुर है, परहिया है, माल पहाड़िया, अर्जुन पहाड़िया, ये सब प्रिमिटिव ट्राइब्स हैं। इनके हेल्थ सीकिंग बिहेवियर इतना परेशान करने वाले हैं कि इनको अगर घर बना के दे देंगे आप तो उसके अंदर में वो झोपड़ी बना के रहेंगे। तो ये समस्या है। उसको डील करने के लिए हम लोगों ने क्या काम किया है, अकाई जी बताएंगे कि हम लोगों ने प्रिमिटिव ट्राइब ग्रुप से ही आशा वर्कर को सेलेक्ट किया। तो ये सब चीज हम लोग कर रहे हैं, तो नीचे से इस सब चीजों की शुरुआत हो रही। एक क्वेश्चन है मेडिकल से ही कि व्हाट आर द मोस्ट एक्सपोज्ड पार्ट ऑफ बॉडी, सबसे एक्सपोज पार्ट ऑफ बॉडी हमारा क्या होगा? सोचिए। फेस, आईज, स्किन, ओके। मोस्ट एक्सपोज पार्ट ऑफ बॉडी है लंग्स, because we are inhaling 700 liters of air in 24 hours. 700 लीटर हम हवा जब ले रहे हैं तो मोस्ट एक्सपोज पार्ट ये होगा। तो ये डिपेंड करता है कि हम लोग डेवलप्ड स्टेट में पॉल्यूशन से मरेंगे और बाकी जो खदान है और माइंस है वहाँ बाकी सिलिकोसिस होगा, निमोकोनियोसिस होगा, है ना। तो ये सब चीज़ों से हम लोग को परेशानी होगी। तो इन सब को ध्यान में रख के आपको बनाना पड़ेगा कोई भी स्ट्रैटेजी और कोई भी प्लान। कोई एक हर जगह के लिए कोई एक कार्यक्रम आपको बनाने से नहीं होगा।
सर, if I can just interrupt there. अभी ये आयुष्मान आरोग्य मंदिर, तो आप बता रहे हैं कि झारखंड में इतना डाइवर्सिटी है, एक जगह माइनिंग है, elsewhere आदिवासी communities have a particular so how has आयुष्मान आरोग्य मंदिर implementation taken off? शायद बहुत मुश्किल होगा कि वो 12 comprehensive primary health care services जो अभी डिलीवर करना है, हाइपरटेंशन मेडिसिन देना है, डायबिटीज स्क्रीनिंग होना है,
इसमें
कैसे?
कोई परेशानी नहीं है। एक चीज जस्ट हमने ओवरव्यू के लिए इन सब बातों को बताया। एक जगह है कि आयुष्मान आरोग्य मंदिर, मंदिर टर्म से भी कुछ परेशानी है, कुछ कुछ जगह में इस टर्म को एक्सेप्ट नहीं कर रहे, एक समस्या है, ठीक है। तो वो भी आ रहा है समस्या, लेकिन इसको जस्ट हम लोग इग्नोर कर रहे हैं। तो भारत सरकार का जैसे एनआरएचएम कब से चल रहा है? 2006 से चल रहा है। अकाई जी 2006 से एनआरएचएम में है और उस समय से बिल्ड कर रही हैं, उसमें लगी हुई हैं, पूरी जानकारी इनको है। लेकिन 2018 में आयुष्मान भारत स्कीम आया। आयुष्मान भारत स्कीम की खूबसूरती थी कि इसमें प्राइमोडियल प्रिवेंशन, प्राइमरी प्रिवेंशन, और उसके बाद भी अगर आप बीमार पड़ गए तो आज के बाद उसके लिए आपको आपके पास प्रधानमंत्री जन आरोग्य योजना इंश्योरेंस का कवरेज भी है। तो सीबैक फॉर्म एक होता है, कम्युनिटी बेस्ड असेसमेंट चेकलिस्ट। मैडम उसको उन्हीं से हम सुनेंगे कि कम्युनिटी में जाके घर में उस फॉर्म को भरना है। उसकी बुनियाद, घर की बुनियाद, रहन सहन, ट्रैक्टर है, साइकिल है, कैसे लिपा पोता हुआ है, और लोग रहते हैं, क्या खाते हैं पीते हैं, कौन अर्ली डेथ क्या हुआ, वो सब सीबैक फॉर्म में आता है। वो फॉर्म जमा होता है आयुष्मान आरोग्य मंदिर में, उसमें से पिकअप करती है कम्युनिटी हेल्थ अफसर। कम्युनिटी हेल्थ अफसर एक न्यू कैडर है। तो 1,75,000 हम लोग को पूरे देश में बनाना था आयुष्मान आरोग्य मंदिर, अभी हम लोग 1,80,000 से पार कर गए। आयुष्मान आरोग्य मंदिर क्या है? जो पंचायत लेवल पे हेल्थ सब सेंटर है, अभी भी एग्जिस्ट कर रहा है, उसी को हम लोग येलो रंग से कलर कर दिए, उसी में कुछ फूल पत्ती बना दिए, उसमें एक सीएचओ को पोस्ट कर दिए, तो वो बन गया आयुष्मान आरोग्य मंदिर। अब है कि सर्विसेज क्या होगा? तो हेल्थ सब सेंटर में पहले क्या सर्विसेज दे रहे थे? पेशेंट आता था तो उसको डिलीवरी करा देते थे, उसको ओपीडी में कुछ दवा दे देते, कुछ ब्लड टेस्ट कर लिए, मलेरिया देख लिए, लेप्रोसी देख लिए, टीबी का कोई भी स्क्रीनिंग वगैरह कर लिए, रेफर कर दिया, यही काम करते थे। लेकिन अब अभी हम लोग OEEE जोड़ दिए। OEEE मतलब, इससे याद रख सकते हैं कि कॉम्प्रिहेंसिव प्राइमरी हेल्थ सेंटर में एक्सपेंडेड पैकेज ऑफ सर्विसेज और 12 पैकेज ऑफ सर्विसेज क्या क्या। OEEE, ओ से ओरल, नेशनल ओरल हेल्थ प्रोग्राम हम लोग चला रहे हैं। सीएचओ को ज्यादा कुछ नहीं करना है, मुंह में सिर्फ टॉर्च जला के देख लेना है कि वेदर इट्स डिस्प्लेसिया और कलर चेंज और सम फाइब्रोसिस और समथिंग एल्स, उसको रेफर कर देना है प्रॉपर प्लेस पे। दिस इज स्क्रीनिंग एंड प्रॉपर रेफरल हो गया। OEEE, ई फॉर इमरजेंसी, इमरजेंसी केयर हो गया। दूसरा हो गया आई एंड ENT। एक ई से आपको आई और ENT हम लोग देंगे, तो वो एक सर्विस हो गया। और एक ई बच गया, उसमें इमरजेंसी एल्डरली एंड पैलिएटिव केयर। इसमें एक मेंटल हेल्थ जोड़ दीजिए। एक और सवाल है कि सबसे लार्जेस्ट मॉर्बिड कंडीशन वर्ल्ड में क्या है, कौन सी बीमारी है? लार्जेस्ट मॉर्बिड कंडीशन। मरने का तो आप कैंसर बोलेंगे कि इस्केमिक हार्ट डिजीज बोलेंगे, मॉर्बिड कंडीशन कौन है? आश्चर्य होगा। मेंटल डिजॉर्डर इज ए लार्जेस्ट मॉर्बिड कंडीशन इन वर्ल्ड। दूसरा भी और आश्चर्य होगा, फाइलेरिया, ये मॉर्बिड कंडीशन है। तो इन सब के हिसाब से आपको बनाना पड़ेगा। तो हम लोग सीबैक फॉर्म पर सर भर लिए, घर में जाकर उनको चेकलिस्ट कर लिया। उसके बाद में आयुष्मान आरोग्य मंदिर में आ गया वो फॉर्म, सब स्क्रूटनी हो गया। उसमें देखा जाएगा सर कि उस सीबैक फॉर्म में क्या क्या नंबरिंग आता है, 4 नंबर 5 नंबर आ गया तो ये हाइपरटेंशन के लिए एलिजिबल है, इनको उनको बुलाया जाता है।
Sure.
फिर आयुष्मान आरोग्य मंदिर में उनका हम लोग ग्लूकोमीटर से टेस्ट कर लेंगे, ब्लड फॉर शुगर और बीपी चेक कर लेंगे। अगर हाइपरटेंशन उनको डिटेक्ट हो गया तो उनको भेज देंगे अपर लेवल में पीएचसी में। पीएचसी में डॉक्टर्स होते हैं, आयुष्मान आरोग्य मंदिर या हेल्थ सब सेंटर में डॉक्टर्स नहीं होते हैं, ठीक है। तो पीएचसी में डॉक्टर विल प्रिस्क्राइब एंटी हाइपरटेंसिव ड्रग, एंटी डायबिटिक ड्रग, और डिस्पेंस करने का पहला डोज वो दे देंगे पीएचसी में। उसके बाद में नीचे भेज देंगे कि आप वहीं पे अपना रेगुलर चेकअप कराते रहिए और वहीं से दवा लीजिए। कोई कॉम्प्लिकेशन फर्दर होता तो फिर मेरे पास आ जाइएगा।
Sure.
ठीक है।
Thank you, sir. So, of course, you have beautifully explained how in theory this is supposed to work. An amazingly designed program rolled out nationwide, and sir mentioned about 180,000 odd centers across the country which have been rolled out. A massive exercise, which is amazing. But at the same time, now the big challenge is, like you were saying, how do you make those 12 comprehensive primary health care, elderly care, palliative care, hypertension available at the grassroots across a very diverse country like India? Thank you, sir. We'll just come back. We have Ms. Akai Mins, who has a very unique position in trying to bring into the state health system an activity that is normally considered as something that NGOs will do, right? Community processes, community engagement, deep community engagement. Not, pardon the term, but not just making a committee and then, once a month it meets, but really getting women, elderly, and children on a periodic basis across the state in participatory learning. So, ma'am, can you share a little bit? Because from my experience as a person from outside the government, it's very difficult to bring in deep community engagement into government spaces, mainly because it is a very, everything guideline पे होना है ना, ऐसा participatory process अक्सर थोड़ा मुश्किल होता है, सरकारी apparatus से work करना। तो कैसे हुआ और क्या-क्या challenges है, और particularly for a state like Karnataka, हमारे में आदिवासी कम्युनिटी कम है, 8 to 10% I think. तो what lessons for a state like Karnataka? Briefly, ma'am, sorry.
See, community is same everywhere. Okay, government norms and programs are same in every states. But like when you thinking about working with the community, because I am responsible for communitization under NHM. So like I've joined NHM in 2010 and I've seen that all things जो प्रशांत जी ने कहा कि जो एक सेट नॉर्म्स है उस पे हो रहा है, एंड कम्युनिटी की ऑनरशिप हेल्थ के लिए कुछ नहीं है. And like when you want to work with the community, you have to think out of the box. Otherwise, it will not be possible कि आप एक norms में चलोगे. And because I had done my studies on community development, I'm community expert. So I have a strong feeling that if you want sustainability and ownership for anything, you need that community grassroots institution should be strengthened. और जब NHM में मैंने देखा कि good, Asha is there, only women who is going house to house and telling the information and bringing people in the facility. तो हमने डिसाइड किया कि ऐसा कुछ हो जो कि ग्राम स्वास्थ्य समिति जिसकी परिकल्पना है that is in the Gram Sabha also in Panchayati Raj and also in NHM. तो उसको कैसे strengthen करना और how to make aware at least to women of that home कि health is her own subject, not the state subject. Like, and then I found कि in my state only one exercise is going on in appreciative inquiry method में participatory learning and action हो रहा है. And that time we decided in year 2011 we decided to work together with Ekjut as our technical partner. It was difficult to convince mission director and other team member, but they believed on me. I had a dream and I shared the dream with my whole team. Let's start with this. And we had seen in Santhal Pargana division of Jharkhand as 6 districts with bulk tribal population. We started with 6 district, one block. And even in there, 2 panchayats. Like, and it came up very well. And then we got a courage to request Ekjut to provide technical support for 6 more districts. Like in year 2013-14, we started in 6 districts of different, we have commissionaries of Jharkhand. And Ashas became so empowered. Like they started able to speak to the community, leadership quality, then उनकी जो लोगों के साथ में बातचीत के साथ convincing की capacity बढ़ती गई. And then like we went for the scale in year 2015-16, and NHM ministry also accepted our learnings, and जो बदलाव आया था उसे उन्होंने देखा, and it went to the scale with NHM team. Like Ekjut is providing technical support. They are training our trainers, okay, and they are ensuring that quality should be like वो बेहतर हो. और उसके बाद जो हुआ कि जब अक्रॉस द स्टेट हमारे ये ट्रेनिंग PLA मीटिंग्स शुरू हुई, तो पहले आशा एक व्यक्ति थी जो लोगों को बोलती थी. अब if you go and meet, if you sit in the meetings, you yourself will get motivated, क्योंकि जो बुजुर्ग माँ लोग हैं वो नई जन्मे बच्चे की माँ को कहती है केवल अपना दूध पिलाना और पानी मत पिलाना. So now there is the role has been shifted from Asha to all the mothers, that health is their own subject. Health is not the state subject. And I would like to tell कि हम लोगों ने maternal and child health से शुरू किया ये topic से. We are in the nutrition part now. We had done more than 17 lakhs meetings अभी तक में, जिसमें हर एक मीटिंग में हम लोगों का एवरेज 35% प्रेग्नेंट वुमेन आती हैं, around 60 to 65% tribal or scheduled caste women are there. And good part is adolescent girls, 20% adolescents are also involving in this. And like through this meeting, we have one district, Kodarma, and there one block is Satgama. There, this adolescent girl and women, they stopped 7 child marriages. तो बहुत सारी चीजें हैं जो बदली हैं. And now we are shifting to NCD. Like we started with the help of Ekjut, like in West Singhbhum Sonua block, Ashas are conducting PLA meeting on NCD topic, and CHO is conducting PLA with Jan Arogya Samiti, the same topic on NCD. So that this Ayushman Arogya Mandir, we call Aam Kendra because Mandir is difficult. So Aam Kendra mein, like whole team of CHO, ANM and Asha, and now VHSNC and JAS will work together.
Thank you. Thank you. It's fantastic. Fantastic to hear this, because many of those of you familiar with public health fieldwork will know attracting adolescent youths to health activities is very difficult. Not only in rural, urban, in all things. So it's and elderly and men. Because invariably government health system has become about, oh, it's for pregnant women, it's for antenatal care. It's not for discussing child marriage is a social problem. But PLA has very beautifully brought what is typically called social issues into discussions on health. Thank you very much for the championship work that you do. We'll move to Randeep, sir. We have only 10 more minutes, and Arnab has kindly permitted us to extend till 10 minutes. And we certainly want to hear brief remarks after hearing Randeep, sir. Sir, you have a very unique perspective because you have been a commissioner of health in Karnataka, so in charge of NHM and various processes. And now you are heading tribal welfare. And many of us in the non-governmental academic sector, we look at primary healthcare not only as a health department thing, we talk of intersectorality. So, and one of the case studies today is Tribal Health Navigator, which is actually financed not from health, but from tribal welfare. The money for Tribal Health Navigator in Karnataka is coming from tribal welfare. So, if you can share a little bit about the challenges of getting social welfare, tribal welfare, health, medical education, how should people like us be working in helping improve intersectoral coordination for primary healthcare and health?
Thanks, Prashant, for the question, and good to be here amongst learned minds. I'm sure each one of you has tremendous experience in the sector. Great to hear experiences from Dr. Kamlesh and Smins. It's what I'm going to speak. I'm not a doctor. I'm just an administrator. I've been there, probably seen health through COVID, seen a bit of tribal health now in the department. Health is a state subject. I'm sure all of you are aware of that, right? So it's an extremely challenging exercise to structure a program uniformly across the country. So if NRHM has been able to do it, it's because it leads to a bit of space at the state level for states to also kind of navigate, like the challenges Jharkhand was facing. I'm sure a uniform policy across the country will never work in states like Jharkhand, which has almost 30% tribal population. If you'd seen the graphs that were analyzed there, a state like Karnataka, a relatively progressive state, you may think that health is all hunky-dory here and is doing well. But very surprisingly, just 150 kilometers away from Bangalore, you would have high maternal mortality rate. You'll have infant mortality rate. So there's something seriously wrong in terms of how we are approaching, or even if the approach is right, probably how we are implementing it at the ground level. And that is where efforts like supplementary efforts, like a participative PLA program or the Tribal Health Navigator comes in. Because at the end of the day, government's resources are limited. You can't have ashas at every block. I mean, there are limitations, geographical limitations. You have limitations in terms of economic access of these people. And let's also not hide behind the fact of caste discrimination. We see how caste discrimination actually impacts health. And we have seen it among the primitive tribals. We have seen, the PVTG groups, as well as the scheduled castes. So these are huge socioeconomic challenges that we are facing at the ground level. And that is where supportive structures, what Prashant was mentioning, help us deliver this huge gamut of health schemes onto the ground and say that we have actually reached the last mile. And Tribal Health Navigator is something which attracted Karnataka's health department, because we really didn't have a very clear, focused policy of how to ensure tribal citizens get access to health services. So simply because an average tribal doesn't speak the language you or I. I may be proficient in Kannada, Hindi, English, my mother tongue, but yet would not be able to converse, because it's not only about language, it's about a culture, it's about how we reach out to them. How do you convince a tribal that vaccination is good for you? I mean, how do you convince a tribal that you have to wait till 18 years to get married? These are huge challenges once you get onto the ground. So when you look at aspects like that, I think simply having a resource from the tribal community itself, who's educated in nursing, and putting that person in a hospital, we saw a tremendous impact there in terms of the tribal community stepping out of their houses and accessing the PHC, even though the PHC was, say, about 2 to 3 kilometers away from, there was a huge resistance in terms of why should I go for a preventive health checkup? Why does an expectant mother go for her checks? So once we had this resource at the hospital itself, we found that important link where a comfort factor emerged, then the trust gradually built in, and then you had more preventive checks happening. You had the entire gamut of NRHM programs, which Dr. Kamlesh was speaking about, reaching out to them. And there one did see an impact in the district of Chamarajanagar was where I think you saw great success. Now, having seen that, the state government is now extremely eager to push this across 5 other tribal dominated districts, just to see how will it really work there now. The challenges may be different. Chamarajanagar being will have its own challenges vis-a-vis a Raichur or a Kodagu or some other, because some are hill dominated tribals, some are forest dominated tribals. So we need to see geographical limitations. But all in all, the sum total of what I'm trying to say is that it requires a very convergent approach. If we feel that there is a straitjacket scheme which is up there, you put certain staff, you have a PHC nearby, things will change overnight. That is not the case. So we need to do in-depth analysis, take ground level feedback, take also the inputs of the locals in terms of what their perceived needs are, as well as look at our the macro and the micro indicators, and then have a system that can deliver on the ground. So I've kind of put it in a very practical way, because that is what has been my experience. Because when emergencies and disasters like COVID hit, we would be found grappling to address this situation. So it's better that we do the preventive health screening, as well as provide this access to the vulnerable communities, so that we are well prepared for the future.
Thank you. Thank you so much, sir. And that's really amazing to know that the Tribal Welfare Department in Karnataka will try to push for health and health related things, because this kind of intersectorality is what primary healthcare is about. There's not too much time, but if there are 1 or 2 line comments from one, 2, 3, if you can keep to 2, 3 lines.
Should I just speak like this? Okay. Good morning. My name is Bodhaditya. I teach at Ambedkar University, Delhi, and work with Adivasis in Madhya Pradesh. So, how does migration, palayan ka jo problem hai, उसको कैसे, because I think it falls through intersectoral जब हम schemes की बात करते हैं. So many months you will go in tribal villages, the doors are locked.
Sure. I don't know whether we'll be able to answer it, but let me take just one more. Comments are preferred to questions, but go ahead.
Good morning. My name is Akshay. Research scholar in Gujarat. I wanted to know about how human resources are being utilized, especially when we see at block level, not all blocks are same. At some places, we have a population of 10,000, while other, it might be 3 lakh. While the block health manager or the number of medical officer in charge over here will be same. So how these things are being tackled?
Again, not sure we'll fully address it, but migration, human resource, and one last one from sir.
I just wanted to know how you can link CSR into this, because we're already tied up in the education field with IIMB, the Public Health Center, the Public Policy Center. I think primary health centers and how also along with the ASHA workers, you can try the Anganwadi workers to get involved. So we are building a center where women and child welfare, because that is a primary start. So it's a wonderful subject. It's too what a subject to discuss here, but then we'd like to talk to you, especially the health commissioner, because it's an area where we want to work with you. Thank you.
The CSR part, and then I'll give you the tribal. So CSR Karnataka has always been open to it, be in the health sector, the Women and Child Development Department also, as well as now the Tribal Affairs Department. Because we in the state have seen a relatively good success wherever we have involved NGOs, and not necessarily the local NGOs. We have also had NGOs who have seen success in other states come and deliver here. So the only thing is that I would suggest is that the NGO has to be fairly rooted culturally, and should be able to kind of connect with the local people. Because of the language barrier. 2, also the trust factor needs to be built in, and that takes time, because unless places like Chamarajanagar, which Prashant has worked extensively in. The minute they step in, there is a trust factor. They trust them more than actually they trust the government machinery. So I think that is where organizations can come up and deliver, strengthen our hands, and I'm sure all states would be there. In fact, there are forums in the state level machinery itself where you can approach and push for your proposals.
Interesting, the CS are convenient for CA.
Sorry, we are beyond time. I'm so sorry, but do catch up after. I'm so sorry to interrupt. Sir, briefly. Any of those? Migration का पे था ना मध्य प्रदेश for example.
माइग्रेशन में तो सिंपल है कि उनको जो भी गवर्नमेंट की स्कीम्स है उसको स्ट्रेंथन करना होगा, उनसे उनको जोड़ना होगा। सिंपल यही इसका आंसर है। दूसरा एचआर का बात बता रहे हैं ना, तो नीचे हमारा फ्रंट लाइन वर्कर में हम लोग अगर जैसे लाइवलीहुड मिशन की अगर लोगों की बात करेंगे तो 30,000 से ज़्यादा हमारे यहाँ वो लोग हैं, वो भी कुछ काम कर रहे हैं। साहिया और आशा वर्कर जिसको कह रहे हैं वो भी हमारे तो 41,000 41,000 है, तो उनको वो भी उसमें काम कर रहे हैं। मल्टीपर्पज़ वर्कर हैं 1700, वो भी काम कर रहे हैं। राष्ट्रीय बाल स्वास्थ्य कार्यक्रम के मेडिकल ऑफिसर्स हैं, और कम्युनिटी हेल्थ ऑफिसर जो है वो भी 3,000 से ज़्यादा है, और उसमें भी रिक्रूटमेंट का भी स्कोप है। और 9,000 के आसपास हमारे पास पैरामेडिकल स्टाफ्स है। तो इन्हीं सब से मिला जुला के काम किया जा रहा है। बाकी डॉक्टर्स की कमी है, 4,000 ही डॉक्टर्स हैं। तो डॉक्टर्स के लिए सर एक नया चीज हमारे SCS हेल्थ ने किया है कि यू गॉट वी पे और किसी ब्लॉक के लिए विज्ञापन निकाल रहे हैं। आपको इस अस्पताल के लिए आप डॉक्टर साहब आइए और कितना लाख लीजिएगा आप बताइए। तो उसमें 2-3 डॉक्टर जो भी आ रहे हैं तो 2.5 लाख रुपये तक हम लोग, हाँ, तो 2.5 लाख रुपये हम किसी एक रिमोट ब्लॉक के लिए दे रहे हैं। तो इस तरीके से स्पेशलिस्ट मेडिकल ऑफिसर्स हमारे कुछ करीब से 150-200 ज्वाइन किए हैं, फिर अभी 144 का लगाए हुए हैं। एक चीज आपने सही कहा कि जैसे एक CHO है, उनका हमेशा सवाल होता है कि 15,000 हमारा पॉपुलेशन है सर, और किसी CHO का 5,000 पॉपुलेशन। तो वी आर वर्किंग ऑन दैट, ये कंप्लेन अभी है।
Thank you. But it is a huge issue, the teamwork between, ma'am, any closing remarks?
For the migration, na, like we have regular monthly meeting, participated learning का जो PLA बैठक है। So whoever is migrated from the झारखंड से बहुत माइग्रेशन है, तो PLA बैठक में ये भी बात होती है कि किस घर से कितने लोग गए हैं। So आशा is having that नंबर एंड उनका कांटेक्ट रहता है। अगर वो प्रेग्नेंट हुई तो जहां तुम हो वहां पर जाओ, तुमको एक माँ बच्चे का कार्ड मिलेगा, उसको रखे रहना, जब तुम आओगी झारखंड तो लेते आना। सिमिलरली वी फाउंड गुमला इज द नियरेस्ट डिस्ट्रिक्ट विद छत्तीसगढ़। तो बहुत सारे जो छत्तीसगढ़ के लेबरर्स हैं वो यहाँ ANC करा रहे हैं, PLA बैठक में आ रहे हैं, बट उनकी जो आशा है उसके साथ उनका कॉन्टेक्ट है। सो अब लोग भी डिजिटल मोड को, कम्युनिटी भी जानने लगी है। दूसरी चीज जो सर ने कहा, हमारे यहाँ अभी आशा और आंगनवाड़ी वर्कर एक साथ मिलकर के होम विजिट्स जो बच्चों की है वो करते, PLA बैठक होती है, उसके बाद जो होम बेस्ड न्यूबॉर्न केयर, होम बेस्ड यंग चाइल्ड केयर के लिए जाते हैं। हम लोगों ने पाया कि सोशल वेलफेयर डिपार्टमेंट में जो आंगनवाड़ी वर्कर को भी जो विजिट्स के ड्यूरेशन है दैट इज सिमिलर विथ आशा का HBNC। तो जो साथ में जा रहे हैं, तो आशा के द्वारा जो काम है वो बच्चे के देखभाल की, माँ के देखभाल की वो बात कर रही है, प्लस काउंसलिंग में जो आंगनवाड़ी सेविका है वो सपोर्ट कर रही है। तो एक थोड़ा सा होलिस्टिक वहां पे अप्रोच आ रहा है एंड इट इज कमिंग अप वेरी वेल।
Fantastic. On
एक,
that note,
एक इन्फॉर्मेशन है सर।
sure, very quickly, sir.
1 लाख टेली कंसल्टेशन पर मंथ हम लोग कर रहे हैं। तो इससे भी हम लोग एक मतलब कि सर्विस डिलीवरी में थोड़ा आसानी है। कम्युनिटी हेल्थ वर्कर जो है इसके लिए अभ्यस्त हैं, वो लोग ट्रेंड है, तो वो 3-4 पेशेंट को अपना रखते हैं कि आपको डॉक्टर से हम बात कराते हैं। और 3,000 से ज्यादा हमारे पास स्पोक्स एंड हब मॉडल पे ई-संजीवनी पोर्टल पे 2.0 में हमारा अगर स्पोक से कोई CHO कॉल करती है तो पूरे ऑल ओवर इंडिया में कोई भी डॉक्टर उठा सकते हैं, लेकिन प्रेफरेबली जो हमारे स्टेट के डॉक्टर्स हैं तो कुछ स्पेशलिस्ट हब को भी हम रखा है, जैसे एम्स देवघर हो गया, रिम्स हो गया, CIP हो गया, रिनपास हो गया, तो स्पेशलिस्ट देवघर है।
Sir,
ठीक है,
thank you.
तो इस तरीके से भी हम लोग हेल्थ को प्रोवाइड कर रहे हैं हेल्थ सर्विस।
Thank you so much. We are at time. I want to thank our invitees from Jharkhand who have come all the way, and both of them are practitioners. Thank you so much, sir. And Mr. Randeep has come during the active sessions. The Karnataka House is happening. Thank you so much, sir, for sparing your time with us. And thanks to IIMB for hosting practitioners and administrators, because the classic critique of academia and public policy and public health is sometimes we are a little bit on a parallel track. We are looking at things without sometimes anchoring it within practice. So thank you so much to Arnab and team for anchoring this. Over to you.
Thanks a lot. I think we are really short on time. We actually have some small sort of token plants from Karnataka for you to take. We'll sort of do that over tea break. I'd like to abruptly call this to a close. Can we have a round of applause and sort of thanks a lot. Thanks a lot.
Audience can P block. The next session starts in P and P12.
I just walk into yeah, that's fine.
Yeah.